So, good evening, all, and welcome to this our evening program of what we call it as a PG. We started it calling as a PGNAR, and Sanjay was also asking, sir, is it only for PG? But we started as a PG, but now you can see, Sanjay, people from United this Kingdom, people from Chandigarh and everywhere, and Dubai, they all have started joining this, and it is supposed to be a good academic exercise for that. So. And this today's the program is facial melanosis inside out. What is the secret of uh, glowing skin? Sanjay Kanodia will be telling us. Sanjay is a professor of dermatology, and Sanjay, please accept virtual bouquet
So this
and
is an honor. This is an honor, sir.
and a Rajasthani turban. You must have wore it during your marriage, and I was there. I remember you were looking good, beautiful that time also. So and Dr. Agif Agrawal is Dr. Agrawal. Are you here? Dr. Lalit, can you please introduce
Sure,
formally Dr. Sanjay Kanodia?
sure, sir, sure, sir. So good evening, everyone, and it's really a pleasure to introduce young, dynamic dermatologist from Rajasthan who has created a name for himself in recent years, and I'm very happy to see his progress as a dermatologist. And it's my honor to introduce him. Professor Sanjay Kanodia is working currently at NIMS Medical College, Jaipur. He has, to his credit, some gold medals as well from University of Rajasthan, awarded with C.K. Joshi Gold Medal Award. He has around 30 national and international papers in to his credit. His special interest includes pigmented disorders, urticaria, post-herpetic neuralgia, drug reactions, and vitiligo. So, Sanjay, it's really a pleasure that we will listen to you on a very important topic of facial melanosis. So, over to you, Sanjay, for
No,
your
no, no,
dedication.
no, no. Before that, we have to give
Yes,
him this uh,
memento. Yes,
memento also. Just let me see.
yes.
What is why it is not moving. This is normally we do a prayer also.
Yes.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सत्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य दृष्टिः गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पत्. And also, please present a virtual felicitation to Dr. Sanjay.
So, it's my pleasure again to present to you this certificate of appreciation and this wonderful memento.
Thank you,
Kindly
sir.
accept, kindly accept it.
Thank you. Thank you so much. It's a big honor to me, sir.
Please
Um,
start your presentation,
yes,
Dr.
sir.
Sanjay.
I'm just sharing my screen, sir.
Sure. Yes. Hope this is not that glacier.
Oh,
Is it visible?
right.
Yes, it is visible, and that is why I was scared. It is not a
Is it
glacier.
visible, sir?
It's not that glacier which is in news nowadays.
So, at the outset, I really thank Dr. Dinesh Mathur, sir, Dr. Yos Agarwal, sir, Dr. Lalit Gupta, sir, Dr. Deepak Mathur, sir, Dr. Manisha, ma'am, for giving this honor to present my views about facial melanosis. And it's basically such a big topic which needs a book to be written. But I'll try my level best to concise the things within an hour of our lecture, and mammoth task to be done. I know that it's after this whole day of exercising with patients, it's a very difficult job to study. But I'll try my level best. We say that perseverance is a great element of success. So I'll try my level best to make you sleep by my sleeping PowerPoints. I say it's part. I'll try my level best to give knowledge and take the knowledge from our audiences. So at the outset, we say that colors of different, which are different in the nature, looks very beautiful. But the same color gives enchanting feeling with the suit to our eyes. But the same shades of different color on the face of our human being can be very troublesome. And to many, it could be so much troublesome that it can cause some kind of psychiatric disturbances in the person. So the same facial melanosis, we say, different colors we see day-to-day life from, we say fair color as stunning and then attractive, nice. And there is a common part of thing in India, especially or Southeast Asia, that dark color is considered as evil. But that is not exactly the so. We Asians have a greater amount of melanin in our skin. And that is why we have a greater risk of developing post-inflammatory hyperpigmentation from sun as well as from procedures and other things. And we do have a thicker dermis. हमारी चमड़ी थोड़ी सी मोटी है. And that is why we are able to have better of the things from our Western counterparts. So facial melanosis, if we say, then it's a common presentation in inpatient causing so much of cosmetic disfigurement that it causes considerable psychological impact, especially. It is not giving any problem to the patient, but to the person who is seeing or to the person who is seeing in the mirror, it gives a big psychological impact. Some of the well-defined causes of this facial melanosis could be melasma, Reals melanosis, lichen planus pigmentosus, erythema dischromic perstans, poikiloderma, frictional melanosis, and so many of the things which we'll be just uh, reading about the things. But there are considerable overlap between one of the entity to the other entities. And we cannot define some of the time one entity to the other, but we'll try to just delineate with our clinical features, the dermoscopic features, and the treatment part of the facial melanosis, the roadmap to our present lecture. The etiology could be many, including unknown causes, UV radiations, melasma, especially melasma, the chemical exposure, the allergens, as in real melanosis. So we'll just try to learn more about it. It's not just a black and white thing which we see. It's actually having so many of the variation. So the very first and foremost we see is melasma, which is an acquired chronic pigmentary disorder, and is more common in type 4 and 5 skin, which is more in 7 to 9 times more common in females than males. The prevalence, especially in pregnancy, could be 50 to 70%. And we have seen that females receiving oral contraceptives have almost higher chances of developing melasma. In men, it represents almost like 20 to 26% in malar pattern and various other pattern, which we'll see in dermoscopy especially. The other entity could be the pigmentary demarcation lines of face. These are acquired non-nevoid, apparently idiopathic facial pigmentation, which are distributed over some specific location, such as periorbital areas. We can see the zygomatic areas, the malar area, the root of the nose, perioral areas, and along the mandibular areas. The periorbital pigmentation is most well-known entity in the pigment demarcation line. Many times it has been confused with melasma. These are bilateral symmetrical, homogeneously diffuse gray to dark gray or slate gray colored patches showing progressive intensification of pigmentation. And these are often considered as physiological or constitutional pigmentation rather than a disease entity. We can see different of the lines here on the malar area, the zygomatic area. Even in kids in hypopigmented, we can see different of the lines which are there, and these have typical pattern around the eyes and the malar area. We can see along, there have been many papers on it showing it along the lines of Blaschko and various of the lines which we see in various pictures here. Then seborrheic melanosis is another one of the common entity which we see in Indian patient especially. It's a term used by some of the Indian dermatologists as describe the localized around the nose and the mouth area. And it is in the seborrheic area of the face, namely the alar grooves, which we see here, or the angle of mouth and labiomental crease, which we can see here itself in this patient. Then another important of the entity in facial melanosis is facial acanthosis nigricans, the FAN. The term is commonly used synonymously with and interchangeably with metabolic melanosis and metabolic melasma by an Indian dermatologist. It's because of the reason that many metabolic, in various studies, we have seen that various metabolic problems have been seen, including dyslipidemias or chances of developing more diabetes in these patients. This label of FAN is given to brown to black macular pigmentation on a blurred or ill-defined margin, commonly on the zygomatic, include the forehead, and there is textural changes in this particular thing, that is a leathery or verrucous appearance of the affected area. We can, along with that, we can see that these patients are prone to develop multiple tags around the affected areas. We can see more of the areas. Central pigmentation is also very much common on the forehead in these patients. There has been some part of oil melanosis interchangeably been seen in these patients. Then one important part is frictional melanosis. This is also very, very important acquired pigmented disorder due to habit of rubbing. The facial frictional melanosis is hardly uncommon, but it often goes misdiagnosed and remains large underreport defined. It is postulated that squeezing of melanocytes against the underlying bony structures releases melanosomes to the dermis seen in melanophages after engulfment by the macrophages. And this results in the pigmentation which is seen at the clinical sites, which we can see at forehead or the malar areas. As a part of our clinical experience, we have seen that this presentation of facial hyperpigmentation with a peculiar pattern overlying the bony prominences. The reason for that is that on the bony prominences, there is more friction, and due to which there is more appearance of this very thing. We can see in this patient that it is more on the temple area and around the mouth area. Repeated shaving is considered to be one of the important cause of this frictional melanosis in some of the cases. Becomes a very, very intense planus pigmentosis. It is asymptomatic, sometimes itchy, diffuse, less frequently reticular or blotchy or perifollicular hyperpigmentation, and it might be dark brown to slate gray color. The black macules are presently over the exposed areas of flexure. And along with face, there are multiple other areas of the body might also be involved. We can see another case of LPP, including the neck area. And the typical feature is that majority of facial melanosis are asymptomatic, while LPP could be symptomatic in form of itchiness. Then another important entity is erythema dyschromicum persistens. It is also known as erythematosus or Ramirez or erythema figuratum melanodermicum. It represents numerous asymptomatic, gradually enlarging and coalescing persistent macules of variable size. These initially have erythematous hue, and then these changes into elevated dusky borders, and the lesion eventually becomes more pigmented. We can see one more case of the same. Then a very, very common of the melanosis, which we call as Rehel's melanosis. It is nowadays becoming more and more common because of its etiological factor. It is characterized by diffuse, patchy, rarely reticular pigmentation, often with satellite perifollicular pigmentation of macules and scaly follicular hyperkeratosis. The pigmentation is brown, almost black on the forehead and temples of dark-skinned people, and it is preceded by mild erythema and prurite. The sites of involvement depends on the allergen responsible. That means whenever a person is using more of chemicals, say for on the forehead, on temples, or on the face, on chest, or neck, or scalp, or hand areas, there itself we see more and more of areas. Even we have seen these cases on the thighs and axilla areas. The most important thing is that positive patch test to that cosmetic is always been seen, or most of the time we see positive patch test in these cases. Then another important, though less commonly found in Indian patient, arthros peribuccal pigmented debrock. It's long name EPP. It is characterized by a diffuse brown red pigmentation present symmetrically around the mouth with sparing the vermilion border. We can see in this case that there is sparing of the vermilion border. This is a typical feature of this very condition. The erythema may fluctuate, but pigmentation is always persistent. And we see that it may extend to forehead, temples, angle of jaw, and other of the areas. Then another entity is poikiloderma of civet. It is characterized by presence of reddish brown or red pigmentation with a feature of telangiectasia in irregular symmetrical patches on the convexity and the cheeks of the sides of the neck. In this condition, we can see the typical feature that it spares the neck area, or under the chin area, we find that it's always been spared. And we can see that it is involving rest of the areas typically. Then another of the entity which has also been seen in persons exposed to sunlight especially, it is erythromelanosis folliculars of face. And here itself, we find that gradually progressive reddish brown pigmentation has been seen. In this case, also we find telangiectasias surmounted with pale, tiny follicular papules from which vellus hairs are being lost. The pigmentation involves the periauricular area and sometimes extending to the side of the neck also. Last but not the least, we should not forget the exogenous ochronosis, which is becoming more and more common nowadays because of the use of hydroquinone. Typically, it is associated with the use of hydroquinone and the triple combinations, and it is a rare complication of the same. It develops after the prolonged use of high concentration of hydroquinone in dark skin patients especially, and rapidly after the use of 2% in white skin people also. It is a diffuse caviar-like hyperpigmentation seen typically on the malar area where the chemical has been used, with almost 1 millimeter sooty blue macules in the reticulate pattern. So there are many more of the causes of the same, such as nevus of Ota and other of the causes have been there. We are not considering here itself, but these are some of the important causes of facial melanosis. So what could be the etiology of these cases? These cases could be due to sun exposure, pregnancy, use of certain drugs such as oral contraceptives or steroids, consumption of certain food items, the ovarian tumors, intestinal parasitosis, the hepatopathies, the hormone replacement therapies, use of cosmetic and photosensitizing drugs, as I already discussed, and then certain procedures, repeated procedures which cause inflammation of the skin, and even stressful events are considered to be important causes. Then risk factor could be many, including family, ancestry, chronic sun exposure, hormonal stimuli, the psychotropic and the anxiety traits in these patients. Especially we see that melasma is more common in type 3rd, 4th to 6th, or in persons having very heavy pollution, staying in very heavy pollution areas. The pathogenesis is quite complicated. It could be, we say that melanocytosis or increased melanogenesis or increased vascularization, which is latest of the, of the Cochrane studies are showing that vascularization could be an important cause. So there could be an hyperactive melanocyte. There is the role of reactive oxygen species and inflammation. There's role of protease activated receptors. The defective skin barriers are also considered important, especially in melasma. The vascular component, as I just told, is considered one of the very important cause nowadays in melasma, and accordingly, there are many therapies are being considered as upcoming therapies in melasma. There is role of histamine and mast cells and role of estrogen receptors. So what diagnosis or what investigation to be done in these cases? Well, in general, we can diagnose these cases on the clinical basis, but we can definitely take help of Woods lamp examination, the dermoscopy, which is becoming a very important tool. And our lecture is basically today based on this very part of inside out of facial melanosis. And a latest instrument is mexameter analysis. Mexameter is latest instrument. I'll just tell in a few of the further slides. Before I go further, I would like to emphasize on this very article, which is actually published 2020 and very article by Ankar BS, and it shows majority of the dermoscopic approaches to the hyperpigment lesion of the skin color, especially the facial melanosis. It is from the Clinical Dermatology Review in 2020. So first and foremost, we'll go with the part of dermoscopy of the pigmentary demarcation lines. Here itself, we can see in this these black arrows shows pseudo-reticular pigment network. I would like to draw attention of all the audience that I hope these pictures are quite visible to everybody. Sir, the pictures are quite clear, sir?
Yes, visible and clear. Don't worry.
Yes, they are
Wonderful,
clear.
wonderful. So they are clear. So I would like to emphasize, especially because there will be so many of almost 20-30 pictures would be there, so might be a bit confusing, but I'll try to enumerate the important points. So what we see around the black arrows, we see the pseudo reticular pattern here itself. I'll just demonstrate by my cursor arrow itself. And then around these blue arrows, we can see that there is arrangement of follicular openings. The brown pigment globules are there. And in this circle, we can see that diffuse irregular pattern of pigmentation is seen. This is typically seen in pigmentary demarcation line, which we just see. Then very important now for melasma part. Here itself, we can see that there is a diffuse brownish background in dermoscopy. The pigment globules are arranged in reticular pattern. These yellow stars actually shows these reticular pattern. I hope you can appreciate the reticular pattern here itself. And the brownish background all over. The same, we'll just further discuss the dermoscopy of melasma. The yellow circles shows the reticular network of the things, and then the brown globules are seen around these brown globules are seen at the black arrows, and reticuloglobular pattern has been seen. Again, there is a brownish background, and the black arrow is showing the telangiectasia in this case. Then typically here itself, we can see that at the yellow areas, there are perifollicular areas are there, which are considered with pigment globule, which we can see here. Here it's on the higher side. Then the black arrow shows that there is typical sparing of the follicles. This is a typical feature of melasma. And then there is out of focus linear vessels. These green arrows shows that vascular element is also an important cause of melasma. Then steroids commonly used in melasma, and here itself in the dermoscopy of the steroid damage phase, we can see that there is in focus vessels. These vessels, the telangiectasia been seen. Then atrophy of the skin shown by this telangiectasia. Then ochronosis, very important. You can see that there is a worm-like appearance. We can see that there is worm-like appearance at the yellow arrows, while there are white scale in the red arrows. Along with that, there is telangiectasia. So a worm-like appearance is seen in achronosis of the dermoscopy of achronosis. Then this confluent reticulate papillomatosis, it shows sulci and gyri, which is typically known as cerebriform pattern. It is typically seen with this very part. We can see in these yellow round circles as well as in the boxes itself. So there is one more important feature, that is broken and V-like hairs. The yellow circle, we can see the V-like hairs in there. Then very common condition. Here itself, we can see a pattern, that is hub and spoke pattern. A typical name is given. We can see here that the central white portion is there along the yellow arrows, and brown portion is there along the red arrows. Then typically here itself, we can see the pigment globules, which are also been seen. And at the black arrows, we can see that brownish pigmentation has been seen. This is typical to lichen amyloidosis. Then hyperpigmented pityriasis versicolor. It is also an important cause. Many times we see such cases in our clinical practice, and whenever there is any confusion, we can take help of dermoscopy. Here itself, the yellow star shows the accentuated pigment network. It is typical with hyperpigmented pityriasis versicolor only. And then there are whitish scales been seen. Here itself, we can see the whitish scale in the yellow circles. And then perifollicular white areas, the red arrows, which we see here, are with widening of skin furrows. That is yellow areas, arrows been showing these areas. Then lichen planus pigmentosus, I'll not go very much detail, but we can see the dotted appearance all over. I need not to show so much. We can see around the yellow areas and bluish gray. Rather than brownish background, we can bluish red arrows show the same. Then brownish background is well appreciated. Then again for the lichen planus pigmentosus, hem-like pattern. Hem-like, it's a sieving pattern. Hem means जैसे कपड़े को हम एक सीविंग करते हैं. So hem-like pattern we can see along these yellow area arrows. We can see the same. Then predominant bluish green globules, which we already seen. I'll not take much of the time in this. Then dermoscopy, again here shows that there is speckled pattern of globules been seen. You can see. I'll just enumerate some of the important parts only. Then perifollicular position bluish gray pigmentation been seen along with the, we can see intensely colored globules. We can see the pigmented globules here. Then same, almost the same cobblestone pattern here itself. This part of lichen planus is showing cobblestoning pattern or brownish gray pigmentation. Then again, it reveals, this very picture reveals pseudo-reticular network. We can see here in this pseudo-reticular network is seen along the yellow circle. And again, there is brownish gray background, which is very well appreciated in these cases. Then an important cause of facial melanosis is erythema dyschromic persistans. It also shows the speckled pattern. But here itself, the globules are dull and are situated more deeper. We can see that almost very less amount of brown or pigmentation. It shows grayish globule rather than the brownish one, and bluish gray background rather than the brownish background itself. Then erythema dyschromic persistans also shows the same out of vessel focus and other things which we can see appreciate in these in this picture itself. Then acanthosis nigricans, it shows typical of linear crista cutis and sulci cutis. As we just revive our things of the cerebriform pattern, it is showing the crista cutis and sulci cutis. We can see a typical globule and dots in these cases along the black dots. Then the same acanthosis nigricans, we can see a typical pattern, wavy pattern. We can see here the black arrows and the red arrows showing the same, the crista cutis and the sulci cutis, and the grayish brownish to pale white color we can appreciate in the background. Then pigmented contact dermatitis. Here itself, we can see that there is regular arrangement of the brown pigment all over, and there is a reticular arrangement of the globules all over we can see. And typically there is perifollicular halo has been seen. All the green, you can see that perifollicular arrows have been seen. Then in part of frictional melanosis, we see a pseudo pigment network with patchy distribution that we can see around the yellow areas. And then petulous follicular opening. This is very, very typical of frictional melanosis. We can see that the follicular openings along the yellow dots, we can see that this is typical of petulous opening being seen in this frictional melanosis. Last but not the least, this is last dermoscopy slide, the seborrheic melanosis, which we just saw in the pictures. This is the ella of the nose we can see here, and we can see that pseudo network, the bluish circle we say, and dilated follicles. It is not the petulous follicles, it is the dilated follicles with whitish yellow plugs we can see along the nose, ella of the nose. So to just summarize all of the things, all the entities in a single chart, I've tried my level best to just see the things. There are 4 or 5 parameters, especially the background color, the globules, the pigment pattern, the vessels, the scales, the follicles, and special features. So we have seen all the features in different of the entities. I'll not go in again detail of the same. And accordingly, we can diagnose by dermoscopy some of the important because these melanosis are overlapping, and that is why it is very important tool to diagnose these cases. Now, maxameter, as I already told, it is a tool to measure the 2 components, especially responsible for color of the skin, melanin and hemoglobin, that is erythema. It emits 3 specific wavelengths. As the quality of emitted light is defined, the quantity of light can be absorbed from the skin and can be calculated. And that is why this very instrument can be used, the parameters can be used as a prognostic marker of the treatment patch. So probably we have reached the half dose of diazepam if everybody is awake on the part. So managing facial melanosis. It's a very, very difficult job to manage facial melanosis because these are recurring condition. So we can divide this part of management into three important parts. The one part is counseling, the other part is the medical management, and the third part is the peels and lasers and procedure. What I consider that counseling remains the most important part in managing facial melanosis. The reason being, it is having a high impact on the quality of life because patients with facial melanosis, they have lower social self-esteem, and emotional well-being of patient has always been disturbed. Because if patient himself or herself is not so much conscious, then the surrounding people makes the patient more conscious. So it causes a lot of cosmetic disfigurement with considerable psychological impact on the patient, and that is why a proper guidance, route, roadmap to the treatment part, and a very important part that expectation management is to be dealt from the part of counseling. So to discuss about it causes and remove the causes, the modes of therapy which you would be using in that patient, and very, very important that expectation management is important because whenever a patient is coming to us, the expectation is as high as this and our treatment is here, so we have to just balance that part of treatment in our part of in managing the patient. So the first very thing is the removal of aggravating causes, then vigorous photoprotection, the active pigment reduction with topical agents or the physical modes of therapy. So I'll not go in detail of each and every of the things. I'll just enumerate few of the Cochrane points from the Cochrane studies. The newer concept in the sunscreen is that visible light, yes, infrared light, are also responsible for hyperpigmentation. We used to learn that it is basically UV light, but it is the reactive oxygen species and DNA damage in due to visible light and infrared light. This infrared light provokes the activation of endothelin receptors B and mitogen activate protein kinase, which actually facilitate the melanogenesis. So the sunscreen containing iron oxide are effective against hyperpigmentation in visible light induced melanosis, and systemic antioxidants such as vitamin A, C, E, and carotenoids are also very much helpful. The sunscreens have strong, there is a strong evidence that the sunscreen with UV and UVB protection of SPF 30, there are many sunscreen coming with SPF 50 and others. So SPF 30 is sufficient, and sunscreen with both UV and visible light protection are important adjuvant to the therapy. Higher SPF is recommended and reapplication may be considered, and water resistant sunscreen is used to be used in physical activities. Then the very important part of our treatment should be cosmetic camouflage, because we cannot give immediate relief to the patient, and many times these therapies are resistant. So this fill lesions can be easily camouflaged with powders, liquids, and other things. In part of current therapies, we know that hydroquinone still remains the gold standard of melasma and facial melanosis. But in that, basically, it is a triple combination with side effect profile has also come. So we need a better alternatives. Topical steroids aim to suppress inflammation, and inflammation excites melanocyte and stimulates melanocyte production. So skin becomes atrophied. And this is the reason what I did, that I searched for hyperpigmentation, that why skin whitening and other of the things are very much important. There are two school of thoughts. That one school of thought says that we should treat facial melanosis. The other school of thought says that when it is a recurring and rebounding condition, why we should treat it. So you can see that when I searched for hyperpigmentation, there were almost like 64 lakh results were there. When I searched for melasma, then there were 80 lakh results. When I searched for skin whitening, there were almost like 11 crore results were there. We can imagine how many people are searching for skin whitening, and they are actually reaching for this very part of thing, that is the topical steroid damaged face, and ultimately the condition could be even worse. So what I think, or what I propose to the house, is that even if we think that this is a rebounding condition or a recurrent condition or less responsive condition, we dermatologists can serve better in terms of knowing that there is inadvertent and irrational use of steroid can be prevented. And we can at least prevent the same by keeping the patient counseled about the steroid cream and keep the patient in our supervision. So an important question is, how far is this triple combination with hydroquinone is rational to use? So to tell on a simpler side, uh, the consensus treatment, or we say that Cochrane study says that hydroquinone 4% is better than 2%, especially in Indian skin, and hydroquinone preparation more than 5% are not recommended due to irritation, except for the refractory cases. Now we are finding more and more beauty clinics in our cities and everywhere, and there itself, we have found that more and more of use of hydroquinone preparations, they want to make the skin, and there are more chances of contact sensitivity. So we have to avoid that we should use only 4% of hydroquinone at the maximum. The pigment lightening by hydroquinone becomes evident after 5 to 7 weeks. So we have to give a rest of, we have to give the ease of things for 5 to 7 weeks. There are many formulas, Kligman's formula, modified Kligman's formula, Patek's formula, Westerhoff formula. So in those formulas, the preparation of hydroquinone with different steroids are being used. So a question arises, which steroid is better to be used? The studies have shown that various steroids such as dexamethasone, hydrocortisone, or mometasone can be used, but only fluorinated steroids prove to be more efficacious and safer than non-fluorinated, such as fluocinolone acetonide or fluticasone. The evidence-based studies have shown that triple combination with fluocinolone are most efficacious and should be the first line of treatment. Mometasone is very, very commonly used, but we should know that it early skin tightening effect, but is also having potential of rebound pigmentation, and the side effects could be seen as early as 8 weeks. A question arises that when to start and when to stop the triple combination. Well, treatment with hydroquinone could be continued at least for 3 months or up to a year, but we should have break in these periodical intervals. We should use alternative therapy without steroid and without hydroquinone, and long-term use of on face, generally more than 12 weeks, should be reduced, and regular medical follow-up should be there every 3 months to 6 months in these patients. So what could be used beyond hydroquinone? There are many new and emerging treatment options. I'll just name some of the things because of paucity of time, I'll not be taking much of time in explaining. There are different level of evidence. We can see that I'll just take few of the slides here. That linoleic acid, the N-acetyl-4-cysteamine phenol, different of these non-steroidal or non-triple combination preparations are having different results. So there can be arbutin, aloeskin, resinol, or flavonoids. All of these are having different effects as per studies. There could be licorice extract, then pyrcyanidine, then acidified amino acids. Even coffee berry extracts, mulberry extracts are being used, and pycnogenol as oral therapy. Soy milk and licorice are also being used. Then latest of the latest is the turmeric acid. It is used both oral as well as topical and injectable form. It actually inhibits plasminogen pathway, and this is very, very important is nowadays in the treatment of melasma. So other of the newer agents such as old wine and new bottle, that is flutamide topically, is nowadays being used, and it is having anti-androgenic effect, and that actually results in reduction of facial melanosis. So if we want to summarize all of these practical features, then we can see that there are different effects of the different agents, from the down regulation of the tyrosinase by the retinoic acid to the anti-inflammatory action of the hydrocortisone or the steroid and the phytosterols, then antioxidant of the vitamin C and vitamin E, then inhibition of the tyrosinase glycosylation from various of products, then tyrosine inhibition could be there. So different mechanism act on different, and what we need that some of the preparation should be there where all of these mechanisms could be involved. So the latest of the latest researches shows that we are working on even on the molecular and the DNA level, and the quest of finding newer depigmenting agent has been shifted to the DNA level. That is, nowadays, scientists are acting on the antisense oligonucleotides, that ASOs, which modulates the synthesis of key enzymes of melanogenesis, namely the tyrosinase, the TRP1 and TRP2. And therefore, there are new medications which are targeting mRNA at translational level. So in latest, probably in few years, we can find new of the therapies. So modes of medical management, priority should be given to the steroid-free or steroid-sparing agents. The use of triple combination should be used at the least possible time, and to switch over to steroid-free or newer agents and use of oral agents. So not to forget about the chemical peels. I'll not take much of the time about chemical peels, but which chemical peel could be importantly useful. So level of studies shows that it is only glycolic peel has shown the most promising results, but that too in non-randomized and controlled studies that could not be the first line of therapy, but could be used. The lactic acid, the salicylic acid, and Jessner solution could be alternative. The level of evidence could as be. And superficial medium to medium depth peel should not be used in Indian skin because there are very high chances of post-inflammatory hyperpigmentation. Then not to forget about lasers. Nowadays, each and every clinic is having lasers in their setup. So which laser is effective in facial melanosis or melasma? It is basically the Q-switched Nd:YAG laser only with the fluence of 1064 nanometer. This typical of the finding has been shown by many studies that fluence of less than 5 joules per centimeter with spot size of 6 and frequency of 10 hertz only. So all the parameters below this are useful. If you go above this parameter, then there could be higher chances of the epidermal damage, and then it can even cause more hyperpigmentation. Rest, other of the lasers are in quest or in line up with treatment, such as Q-switched Ruby laser or erbium YAG laser or pulse dye laser. Even fractional CO2 laser could be used, but they should be used with caution in type 5 to type 6 skin. So what are the bad prognostic indicators? Last but not the least, few more slides. The bad prognostic factors could be the phenotype 3rd to 6. That means first and second are less. That means dark skin people are having more chances. The genetical and familial predisposition. The long-term melasma in spite of treatment for more than 2 years. The history of procedural intervention in these facial melanosis. That means multiple procedures even can lead to prognosis. Treated by 2 physicians. Yes, this is very much important that multiple treatment by multiple dermatologists can even be a bad prognostic factor. Then long-term self-treatment with steroids, we already know. Ochronosis and mixed type of melasma, that is dermal or even epidermal of the melasma. So what are the final stay home points, not the take home points, because we are staying at home itself. The facial melanosis management requires multiple approach. A proper diagnosis is very much important because many, just such as pigmented demarcation lines and Rayleigh melanosis, these have different etiologies, and accordingly we can give assurance to the patient that okay, this will not going to increase or this will going to increase, or you have to use or you have to discontinue the use of such and such chemicals. So dermoscopy could be a very useful tool in identifying the exact condition. And one product or one ingredient is not enough. We need to have different therapies at different stages of melanogenesis, which can be helpful at various stages. And newer and upcoming therapies are way forward in terms of current therapies, which we are there. And not only the results from the cost efficacy, but the safety should be very important. Laser therapy should be used if other alternatives fail to have any other. So probably my sleeping dose of PowerPoints are almost filled. Care not what they say about the color of the skin. Let the brilliant light blind them. So thank you so much for listening to me. Stay unfair and stay beautiful. Thanks for this patient listening. Thank you so much. Over to you, Dinesh Mathur sir and Lalit sir.
Thank you very much, Sanjay. It was really indeed, it needs a standing ovation, but you said that stay home points. So let us now, the time is coming that it will be take away point, like we take away of these
Burgers and pizzas.
Fantastic, fantastic. You have done a very good job, and I really appreciate you.
Thank you so much, sir. I tried my level best to concise the things because I need
It
to.
was a beautiful presentation, and people, those who missed it something very important. This is for the dermatologist. It was a
Dinesh, can
very.
I ask a question, please?
Oh yes,
Yeah,
Dinesh,
yeah.
yes.
can
Yes,
I
ma'am.
ask?
Yes.
Dr.
Ji, ji,
Shakuntala
ma'am.
Lavasa is a famous allergologist at Chandigarh. She is from our batch.
Ji,
Right.
ji, ma'am.
While complimenting you for excellent presentation, which covers almost everything,
Thank you,
I
ma'am.
would like to ask, a couple of questions from you.
Ji,
One
ma'am.
is, you said that skin is involved, but suppose if we feel that mucosa is also involved,
Ji, ma'am.
so does it change method of management, and does it change prognosis? That is
Def-
number one question. And number two question is that what is the role of allergens, particularly of the parthenium and also of the food allergens? Because if we identify allergens, then lot of things can be actually prevented also, suppose if there is a food allergy and all that. So in your experience, what percentage is the contributed by allergens, and accordingly then we will be justified to do the allergy test and offer treatment, because indeed this problem is absolutely psychosocial. Because
Definitely.
even if there is a very very small spot on the face, the ladies are so sensitive that they would worry about it, and at melanosis the extent is tremendous. And also, in your experience, what is the difference between the genders in melanosis? Is it more common in females, or it is found in the males also? So couple of questions, but I
Yes.
hope you will patiently answer
Yeah,
every
I
question.
would love to answer your questions, ma'am.
Yeah,
It's thank you for
thank you.
appreciating. Thank you for appreciating the things. So, if we say mucosal to non-mucosal of the treatment part, uh, the prognosis is bad in the cases where the mucosa has also been involved. And the very important part is the treatment. What we can offer the treatment at other of the cutaneous site, we cannot offer at the mucosal sites. Many a times we have seen LPP cases or lichen planus cases in the oral mucosa, and there itself we can only reassure the patient. I generally, what I do to my patient, I reassure the patient by saying that if you get any injury on any of the surface, what do you get? You get hyperpigmentation. So it's a nature's mechanism that you will get hyperpigmentation wherever you have protective mechanism. So it is not that you should get that pigmentation treated or completely vanished. It is a thing that it is a non malignant process, because many a times patients who are coming with mucosal involvement, they are having, say for oral mucosa, they are having one important thing in their mind, that is it not a cancerous condition or
Mhm.
precancerous condition.
Right.
So there itself the patient needs a proper counseling, that it is totally a benign condition. So
Okay.
what we can use, if at all, many a times it is not at all troubling, but wherever it is troubling, then the modes of therapy are different.
True.
This is one
And
important thing.
what she told about the
So
allergen,
can I
even in
ask,
even
related to this, can I ask that if it is self-limited, then how do we decide that who should be left alone, and how should we sort of monitor so that we know that this is the time that now self leaving alone is not sufficient, and we should be now offering treatment?
Definitely,
So what are the
definitely.
factors which decide?
It's only on the part that I generally ask my patient that remain in my follow-up. Click serial pictures.
Yeah.
Serial pictures. If at all you find that this is increasing beyond anything, then they can communicate immediately, and accordingly we can change the part of the treatment. And
Mhm.
as I said, majority of the patient does not require any kind of treatment except for reassurance. So there
Mhm.
itself we can do a biopsy, a histopathological examination could be done, and then accordingly we can plan the further part of treatment. Now the second part, the second question which you asked, that allergens
Allergens. Yeah,
basically.
yeah.
So in my own practice, I have not found, except for in few cases, that these allergens are basically responsible. They are responsible.
you may deal with pigmented contact dermatitis. You
Yes,
talk about
in
that.
those cases only, because uh, there are variety of cases been coming, and there is overlap from one case to other case. So what I have found that only 5% of facial melanosis cases are actually having some allergens responsible.
Right.
And very importantly, many a times we are going for food allergy test, and
Hmm.
there itself, a vegetarian person surprisingly having allergy to fish proteins.
Mhm.
So there itself, it becomes very dicey to say
In
to the
fact,
patient.
I told Shakuntala to have a presentation or a lecture on these. She is an expert.
Definitely, we would love to hear.
Yeah, actually, at the moment I'm calling from the ICU where my mother is admitted,
Yes,
but
yes, I
today
know.
she's
I
at
Oh,
know. I know.
good job.
That is what
So
I
later
thought.
on, as soon as she's okay, I would be
Yes,
talking on
yes, yes,
food
yes,
definitely,
sure,
allergy
sure.
we
because
would
this is
love
a
to.
subject which I love.
No, no.
Bilkul.
But I would like to ask you that, what did you not find any role of, milk allergy and the parthenium allergy in melanosis contribution in melanosis? Like,
And
did you review the literature and did you have a look at the papers?
I did review.
Parthenia is not the cause for melanosis in this sense.
That's right.
It's
That's right.
one of the most commonest cause of allergic contact dermatitis, but not
Mhm.
known for the
Not melanosis.
melanosis part.
Okay,
In
okay.
yeah, in facial melanosis, parthenium or milk allergies have not been important.
Uh-huh.
Anywhere
When
near.
when you talked about the fish allergy and you said that vegetarians not eating fish and the fish coming positive, but I should put you wise that there are so many things in which fish is found. Say for example, these creams, the cosmetic creams,
Yes, yes, yes.
all those things they would contain fish. So many capsules they would contain fish.
Could be
So
possible.
many medications they would contain fish. So even
Could be.
these glucosamine and chondroitin sulfate, which is so much in vogue, which people keep taking for healthy joints, that also contains
Definitely.
fish.
That
So therefore,
that
in vegetarians also fish can be a source which people are consuming unknowingly, and it can
could
be a
be
cause of allergy.
All right, that's something
very
very
important.
knowledgeable.
And regarding the gender wise part, we see more often that female patients with facial melanosis. The important
Hmm.
reason could be that females are more conscious, though it could be there in male and female both.
Yeah.
But females are more conscious about even you rightly said that even a single spot on the face could be very
Yes.
troublesome to the patient.
Do you,
So,
do
in
you use Mexameter? Do you use Mexameter or have you?
I have not used, sir. I just found it
Well,
in
I
literature.
tried to procure Mexameter a lot, but somehow or other, no good Mexameter I could see.
Yeah, they are.
Yeah.
They could be helpful in prognostic parts,
I
sir.
know, I know. When I was trying to give some topic for this thing, I thought, but probably no, it's hardly. All these company people, those who are making these things, probably they might be having, but otherwise, most of the dermatologists they do not. But you had an excellent collection of all these dermoscopy pictures and all
Yes,
this.
sir. This is very much helpful in diagnosing the exact
Please,
entity.
what is there in the chat box? Some must be some. Let me see. In chat box, well, people are very appreciative and praising you, Dr. Palvi. Excellent talk, very informative. Old wine in new bottle. Riaz Amir, good revision for for private practitioners as well. Ajay Singh, excellent presentation. Thank you so much. Pallavi, in some cases we have to screen for endocrine disorders, of course, hyperthyroidism and Addison's. Rather than I think hypothyroidism is more important. All these melasma cases, I have uh, they are very commonly associated with hypothyroidism. Not
कैसे हो तबीयत कैसी है आपकी
uh, I don't think so. Anybody else is speaking. I thought that I should mute someone, but anyway. Riaz Amir wants to know dye, photopigmented dermatitis, mustard oil, macular amyloidosis, and all these things. So, would you like to comment over mustard oil, pigmentation, all these things?
Yes. Mustard oil, in Indian perspective, mustard oil is very important part of facial melanosis. That is oil melanosis, which we usually see, and this is typically found on the temple and the side of the cheek
Don't
region.
you think it was amla and mustard? It is because of these toxic and pollutants in that.
That's right. Adulterants which have been there.
Yeah.
So they are the important cause in and along with that melanosis we find the comedones along the side of the they are the important features in these cases, sir.
All right, thank you very much. It was a nice evening. I really liked it, and thank you very much those who attended. So let us call it a day. Okay,
Thank you so much, sir.
thank you.
It was a great feeling to be here on this platform as a presenter,
Ah,
and
no,
and I do remember my post graduation days where you used to teach us, sir.
no, no.
And today itself, I got the opportunity to just present my ideas about some of the part. So
No.
thank you so much, Dr. Dinesh Mathur, sir. You are always a great mentor and great teacher to us. Thank you so much.
Okay, bye bye.
Thank you.
Thank you very much.
Bye,
Bye.
everyone. Bye, everyone. Thank you
Bye-bye.
so much.
Good night. Good night.